Hello. Hello. Are you guys able to hear me? Hello. Can you turn on your mic? Okay. Thank you so much. So before starting our session, let me address that that nowadays our mentors are trying to settle them up in US. So that's why there was a lot of delay in the session. Really sorry for that. And thank you so much for understanding. Thank you so much for your support in such a hard days. So from today onwards, we yesterday we had a meeting and we decided that whenever Dr. Moaz and Dr. Mahi get time, they're going to be settled within a week. They're going to take the session. But if they didn't took any session due to certain problems, as you guys know that they are going to be the first year residents having a lot of problems. So I'm going to continue the session at this time. Okay. So this time suits me better. So that's why I'll be taking both of the sessions of UWorld. Along with that, I'll be also taking the normal sessions of first aid and covering the entire concept. So hope so you guys are enjoying the sessions with me as well. So first of all, let me just share my screen. So we discussed almost the entire pathology, but we were already remaining with certain neoplasias. I know that Dr. Moaz already did that with you guys, but I want to have a brief overview of that. Today we are going to cover the entire neoplasias. Along with that, we are also going to cover pharmacology. After that, we are going to be having like a normal session of UWorld. And let me mention one thing from respiratory section. We are going to be more consistent, and all of the tasks all of the weekly tasks would be shared in advance. But there were some problem in the renal system. You guys know we were struggling a lot. Thank you so much. Can you guys just see my screen? Hello?
Yes.
Yes. Okay, that's perfect. So today we are going to discuss renal neoplasias, right? Okay, before discussing any kind of cancers or neoplasia, there is a general rule which you guys have to keep in mind, right? There is a general rule. Before getting your normal cells into cancers or malignant cell, there is a general rule which you are going to follow in entire cancers, in entire concepts, right? Remember, whenever we have chronic irritation of a surface, right? Whenever we have a chronic irritation, it's going to lead to formation of your cancer, right? For example, if you assume cancers of your lungs, right? So the most common causative agent behind that is smoking. Smoking is a chronic process. It means you are chronically irritating the epithelium of your lungs, which is going to lead to cancer, right? Similarly, if you have any renal kind of neoplasia, one of the more risk factor for renal cell carcinoma is smoking as well. Now you would assume that as we are smoking, okay, for the bladder cancer, smoking again comes one of the risk factor. You are going to be having an MCQ on that. They're going to ask you what is the most common risk factor for an individual to develop renal cell carcinoma, that is smoking as well. So the question should arise in your mind, as you are smoking through lungs, how would that cause neoplasia in your excretory system, that is urinary tract? So the answer for that is that all of the toxins are ultimately going to be excreted out through your urinary system. So your urinary system have to come in impact with that toxic substances as they're excreting, right? And as smoking again is a chronic process, it would lead to chronic irritation. So chronic irritation basically leads to cancer's formation. What's the other rule? What's the other general rule which tends to lead into cancers is that we know that inside our body, our cells keep on turnover, right? Like the cells are made, once they are, they become worn out, they become old, they are destroyed, right? That's a normal process which occurs in our body as well. So sometimes whenever the cancers form, whenever the cells formation is more and the clearance of cells is less, for example, if I'm forming more and more cells and there is some problems with, killing those worn out cells or those old cells, I think ultimately again the cells will start growing, and the abnormal growth basically is known as cancer, right? So cell turnover is also really important for that. So these are the concepts which we are going to discuss again and again in all of our cancer sessions. Whenever we have any kind of neoplasias, if it's your GIT, if it's your renal section, if it's your pulmonary section. So I'll be referring towards these common concepts, right? Keep that in mind. So the first topic which we are going to discuss is renal cell carcinoma. It's very high yield, and I guarantee you that you're going to get an MCQ on your real exam, 1 or 2 MCQs on your real exam from this topic. That's really important. The first thing which you should just keep in mind is renal cell carcinoma is a malignant cancer, right? What do we mean by malignant? What do we mean by benign? Yes, can anyone just tell me what is benign, what is malignant? Hello, anyone please turn on your mic.
Benign
Hello?
have only the localized effect, and the malignant had the metastatic. Now the difference.
Perfect. Perfect. So benign is any kind of cancer which stay there in its location. It do not have like ability to spread to the surrounding structure. That's basically benign. So on physical examination, it would be a well circumscribed mass with proper margins, and that would be mobile. Mobile means that you have a constant mass there, you can move it. But if it's a malignant, if it's being spread to surrounding areas, it would be stuck in place. That won't be a mobile. Right, so these kind of things you should just keep in mind in the question stem. They're going to tell you well circumscribed mass, a mobile mass. So you should just think of benign cancer, right? Okay. Another thing which you should just keep in mind is that whenever you see the word carcinoma, right, in the end of any cancer, that's going to be a malignant renal cell carcinoma, right? Whenever you see OMA, only OMA in the end of any cancer, that's going to be a benign cancer. For example, chondroma, right, osteoma. But in the end, if you see sarcoma, that's going to be a malignant cancer. So two things. Whenever you see sarcoma in the end of any cancer name, or whenever you see carcinoma in the end of any cancer cell, that's going to be a malignant cancer, right? Whenever you see only OMA, that's going to be a benign cancer, right? A benign tumor. Is that clear? Hello?
Yes.
Perfect. Now, the first thing which you should just keep in mind is the presentation. That's really high yield, right? So whenever you know the presentation of renal cell carcinoma, that's going to make your life easy, believe me, right? So there is going to be a triad of three things: hematuria, there's going to be a palpable mass, and there's going to be a flank pain. Flank pain is really important, right? So why are we going to see hematuria? The idea is really simple. We have a cancer cell. Cancer cells grow, at a very higher rate. If the cells are growing at a higher rate, it means it needs a lot of blood vessels as well, a lot of angiogenesis. If it have a lot of blood vessels, there is more probability of these blood vessels to get ruptured and appear in a form of hematuria, blood in your urine. Does that make sense? Okay, so
Yes.
if we have a cancer, it's going to be a palpable big mass, right? And flank pain basically, any kind of pain which is referring towards your kidney is going to be referred as flank pain, right? This is really important because once we were discussing our topic, if you guys remember, that is nephrolithiasis. So the same things, hematuria was seen in that as well, but the pain was different. That wasn't a flank pain, right? If it can be flank pain if the kidney pelvis is involved, right? As we discussed, hydronephrosis, touching your kidney, giving you pain. But if the stone is somehow, at this junction between the bladder and ureter, there is going to be a lower abdominal pain. Keep that in mind, okay? So these are your differentials which you should just keep in your mind, okay? So hematuria. Okay, what's the nature of this renal cell carcinoma? As I already discussed, the most common risk factor to development of renal carcinoma, again, in 90% of individual will be a smoking history, right? History of smoking.
Okay.
Okay, that's really important. You are going to be asked this point. Okay. Another thing, it's basically a paraneoplastic syndrome. What do you mean by a paraneoplastic syndrome? That this cancer has ability to release a lot of hormones, right? A lot of secretions. And what would be that? Really important, really high yield. You are going to see a NBME MCQ related to that. That is EPO. What is EPO? Erythropoietin. If you have erythropoietin, what's the function of erythropoietin? It's going to go into your bone marrow and it's going to cause a lot of red blood cells. And what's that condition called? Polycythemia, right? Hello?
Yes, sir. Polycythemia.
Okay, perfect. What else are they going to secrete? That is PTH related peptide, same as that of parathyroid hormone. So on the labs are really important. If you are seeing an individual having any history of palpable mass, hematuria, flank pain, and in the labs they are mentioning that the calcium is high and the phosphate is less. It's a function of PTH, increased calcium and phosphate thrashing hormone. So most probably you should be thinking of renal cell carcinoma. Again, you're going to be asked on this point as well. Okay, what else? It's also going to release ACTH. And once ACTH, ectopic release of ACTH is going to lead to Cushing syndrome, right? Cushing syndrome. Remember, what was your Cushing? Hypercortisolism. Okay? Okay. So the nature of this cancer, okay, from where did this cancer arise? That's really important. Remember, it arises from proximal convoluted tubules, right? From your tubules, it would arise. For example, if this is your glomeruli, your Bowman capsule, your proximal convoluted tubule, so this cancer is going to arise here. and it would love to spread hematogenously. Really important, really high yield. So it loves to spread hematogenously, right, in the blood. So it's going to spread into your renal vein. This is going to be your renal vein, for example, and from the renal vein, it's going to invade into your inferior vena cava. But here lies a really important concept which we discussed in our cardiovascular section as well. An individual with a history of smoking, having renal cell carcinoma, along with that, he was having left-sided varicocele. Why?
Massive fit.
Because of
Left
its
side.
invasion into the left renal vein.
Perfect. If this is our renal vein, your left-sided kidney, your right-sided kidney, we already know that the gonadal vein on the left side are first of all going to drain into your renal
Left.
vein. On the left side, sorry, okay? On the left side are going to drain into your renal vein. But on the right side, they directly drain into your,
IVC.
yes, inferior
IV.
vena cava. So you're going to be asked this question. We have an individual. He's having a history of smoking, having a palpable mass with hematuria. He developed left varicocele as well. It was also seeing in the nutcracker effects. Did you guys remember nutcracker effect? Left-sided varicocele. Okay. Hello.
Yes.
Yes.
Okay, perfect. Sometimes what happens that, okay, for example, if the renal cell carcinoma develops, it's going to invade into your renal vein. As the renal vein is invaded, what happens? Now the venous, return from your testicles are impaired. So what happens? You're going to have dilatation of your pampiniform plexus, which is basically known as varicocele as well. What happened to the temperature in case of varicocele? Increase or decrease? If you have a lot of blood being accumulated there?
Increase.
Increase. So let's discuss a little bit concept of your reproduction as well, right? As we know. Okay. So let's discuss a little bit concept of you're going to be asked this concept a lot. So you know that how the testicles are made. How the testicles are made, right? We know that the testicles are basically made from a structure that is basically your genital ridge, right? If you are having a Y chromosome having an SRY gene, it's going to lead to formation of testicles. Testicles have two components, right? Your Sertoli cells plus your Leydig cells. Okay, so you guys are going to be telling me what's the function of Sertoli cell? Two things.
The cells
But-
make the inhibin, and the
And
other is the
Spermatogenesis.
aromatase.
Inhibin plus
Aromatase.
spermatogenesis, right?
Spermatogenesis.
Spermatogenesis. Yes.
Okay, perfect. And what's the function of your Leydig cells?
They make
Testosterone.
the testosterone.
Perfect. Testosterone formation. And your Sertoli cells are also going to make another thing, if you guys remember, Mullerian inhibiting factor, MIH, is going to inhibit your Mullerian ducts, right?
Yes.
Okay, so let me ask you another question as well. The testosterone is further going to be converted into DHT. Did you guys remember that? Dihydrotestosterone, more potent form of your testosterone, which is going to be, helping your development of male
External
genitalia and prostate.
external genitalia. And this testosterone is going to help develop your Wolffian ducts, right? Which is going to lead to development of three things. SEED. Yes, what's that?
Seminiferous tubules.
Seminiferous tubules, seminal vesicles, epididymis,
Epididymis, ejaculatory duct,
Ejaculatory
and
duct.
ductus.
and ductus deferens. That's really important. So why have I drawn this entire thing? That's really important, right? Because you guys know that Sertoli cells are basically sensitive to temperature, right? Whenever the temperature is more, Sertoli cell won't make your sperms and won't make your inhibin. What's the function of inhibin? Inhibin basically inhibits your FSH, right?
Negative
Yes.
feedback
Controlling
effect.
negative feedback to
Via negative
Feedback
feedback
effect.
mechanism.
yes.
Okay, perfect. And the Leydig cells do not have any influence on your temperature. That's really important, right? Keep that in mind. And why am I discussing this thing? Because in two cases, the temperature is going to rise, which is going to affect these two things, spermatogenesis as well as, inhibitory action of your FSH. while temperature have no effect on formation of testosterone. So two cases which we are going, cryptorchidism. What is cryptorchidism?
Undescended testes when the testes
Undescended
remain in the abdomen.
Perfect.
Or in
So
the
whenever
pelvis.
we are having undescended testes are going to be present in the abdomen. So what happens? In both of these cases, what happens to temperature? Temperature would rise. Okay? Temperature would rise. And increased rise of temperature have effect on Sertoli cells as well as but no effect on Leydig cells. So in both of these conditions, spermatogenesis is going to be affected. You're going to see increased FSH, but formation of testosterone won't be affected. So the secondary sexual characteristics are going to be intact. Is that clear? But no formation of your sperms. Is that clear?
Yes.
Yes, sir.
That was the point which I want to mention. Really important. Okay. So if we, okay, what else you should just keep in mind? For example, whenever we have this kind of cancer, so it's going to spread into renal vein, as we already discussed. From the renal vein, it can travel into inferior vena cava. You know, that's quite simple. So whenever the inferior vena cava is involved, what do you guys think? What kind of physical symptoms or features are we going to experience? Yes. Hello?
Hypertension.
Okay. We know that the lower extremities basically drains into your inferior vena cava, right? So won't we be seeing a kind of edema there?
Pooling of blood will be
Yes.
Lower limb
Pooling of
edema
blood
in the
or
lower
maybe,
extremities.
yes, liver
Perfect.
congestion.
If we have pooling of blood, won't pooling of blood lead to edema?
Yes,
Yes.
Would the edema be unilateral or bilateral?
bilateral.
Perfect.
Bilateral because of IVC.
Yes, perfect. So you are going to see the same scenario in your viewer, and I think that's clear now. Okay. Okay. So you should just keep in mind that it can travel anywhere, right, from the renal vein. Most appropriate location which it have to migrate is your inferior vena cava. Okay. So we are going to have right-sided varicose. Okay, right-sided or left-sided varicose? Left-sided.
Left-sided.
Not right side. Okay. Let's discuss something about your right side as well. Sometimes what happens, we can have formation of thrombus there, right? Okay. What can lead to the formation of thrombus? What do you guys think?
DVT.
DVT.
Injury,
Okay,
injury
DVT
to
can
the
but I think
endothelial
the DVT won't just come through testes. What do you think? If we have DVT, deep vein thrombus, it's going to directly come into inferior vena cava. It can't come through your, the gonadal veins.
From the right side, yes.
Okay. So any condition which is leading to stasis here, right? Stasis. Stasis can be seen in a lot of conditions. For example, if you have a pregnant lady, right? And she's compressing her abdomen due to having a big baby, right? And it's going to compress the, inferior vena cava, it's going to lead to stasis. So sometimes we can have formation of thrombus there as well, right? Okay. And in that cases, basically we can have, thrombus going into your inferior vena cava. That's really important, right? So for the formation of DVT, we have a criteria, if you guys remember, that is Virchow triad.
Virchow triad, this is
yes,
the main.
Virchow triad. And what's Virchow triad? Endothelial damage.
Endothelial damage.
Yes. Stasis. And hypercoagulable state.
Yes.
Okay. Yes, that's really important to keep in mind. So this was all about. Okay, so this was all about, okay, what else can lead to renal cell carcinoma? We discussed one of the acquired risk factor is, a kind of smoking. There can also be some genetic predisposition to formation of your renal cell carcinoma. And what's that? VHL gene mutation, right? Am I right?
Yes.
Yes.
Okay. So before discussing,
Chromosome 3.
okay, let me just make this thing very simple. It's a tumor suppressor gene. Tumor suppressor gene. Okay, as the name indicates, it's going to suppress the formation of tumor. If you do not have this thing, you can't suppress tumor. We're going to have formation of tumor, but not only in your kidneys. We are going to be having tumors in 3 places whenever we have VHL gene mutation. Tumor suppressor gene on 3p chromosomes. And what's that? Hemangioblastoma of your cerebellum, pheochromocytoma, and renal cell carcinoma. So how can this present in your question? That's going to be really simple. We have an individual having cerebellar ataxia, right? With increased hypertension, increased metanephrine level of the urine. Along with that, he's having some kind of hematuria, palpable flank mass. You know, like you can just play with these concepts like that, okay? Okay, so VHL gene is also important for, like, it's basically a tumor suppressor gene, which encodes for HIF transcription factor. What are HIF? Hypoxia inducible transcription factors, right? So whenever we haven't, we do not have that, you know, that suppression of this HIF, we are going to have angiogenesis, right? Angiogenesis. We are going to have increased VEGF and platelet-derived growth factors, which is going to trigger the formation of tumor. Along with that, a lot of blood vessels, and not only in renal cell, in your kidney, but in your adrenal medulla as well, and your cerebellum as well, leading to angioblastoma and pheochromocytoma. Is that clear? Hello?
Yes.
Okay, if the smoking is an acquired risk factor for development of renal cell carcinoma, so male individuals are going to be more affected by this condition, right? And very important point which we should be keeping in mind, that we won't be, it will be a kind of painless mass, right? The pain is going to develop very late in the development of renal cell carcinoma. So most of the time it's going to be painless, right? Not painful mass, right? That's really important to keep in mind as well. Okay. Hello?
Yes,
Hello?
sir.
Yes.
Okay, perfect. So in order to look for the extent of spread of this tumor, basically we do a TNM staining, right? What is TNM staging? What is TNM staging? T stands for the tumor size, the involvement of renal vein, and the N stands for, you know, the involvement of the lymph node.
involvement.
And more importantly, there is going to be respect to retroperitoneal lymph node, because we know kidney itself is a retroperitoneal organ. Is that clear? Hello?
And para-aortic also, I think.
Yeah, a para-aortic, yes. Okay, what else go to para-aortic?
Both
What
testes
else
also,
tumor?
pair organs of the
Testes and
pelvis and
ovarian
Ovarian
tumor, right?
testes.
testes.
Yes, ovarian and
Ovaries.
testis tumor also spread to para-aortic. Okay, that's great. So let's discuss our next tumor, which is really important. That's known as Wilms tumors. Wilms tumor, and I would say a really important point we have, like in Wilms tumor, is it's a tumor of children. Whenever you see tumor of children, you're confused, just go for Wilms tumor. Simple, right? Okay. Again, it's a malignant tumor of your blastema, right? What is blastema? We discussed blastema in detail, if you guys remember. It's a tumor of your blastema. Recall your embryology. Metanephric duct. Metanephric duct interacting with the blastema. Blastema is going to lead to the formation. Okay, let me just review it. Okay?
Parenchyma of kidney.
Yes, that is pronephros. It would degenerate. Mesonephros, again, it would degenerate.
Collecting duct.
Yes, and metanephros, it's going to lead to formation of your bud. It's going to interact with the blastema. Blastema is going to help develop your glomeruli, all of the functional and tubular structure, right? Your proximal convoluted tubule, loop of Henle, distal convoluted tubule. Along with that, your collecting ducts, and all of the other are going to be formed by your bud, right? So this is the blastema. So if it's a tumor of blastema, and blastema further leads to formation of glomeruli, tubules, and stromal cells, remember? Hello? So if I'm just referring towards the tumor of this blastema, so won't I be seeing glomeruli in that, tubules in that? Because the fate of blastema is, you know, is to give you these mature structures, your glomeruli, your tubules, right? So it's a malignant kidney tumor seen in children of your blastema. And if you further visualize it carefully, it's going to be having primitive glomeruli, tubules, and stromal cells. Is that clear? And the average age is 3 years. Is that clear?
Yes.
Hello? Okay, perfect. So if you have tumors in children, it's going to be large unilateral flank mass. Again, it's going to be a flank mass. It's going to be large. And okay, if it's a tumor, would we be having any hematuria due to increased blood vessels in the tumor? Yes.
Yes.
Right?
Yes.
Okay. If we have tumors, like for example, let me just give you a normal concept. How would it lead to hypertension? For example, if this is your kidney and you have a tumor, let's suppose if this tumor is compressing your renal artery, right? Because it's a big tumor, it can compress things, right? So it's more probably going to compress your renal artery. So what would happen to delivery of NaCl to macula densa? Decrease.
Decrease.
Won't it trigger the release of renin?
Renin, yes.
Yes.
Won't you be
Yes.
having hypertension?
Yes.
Yes.
Yes, it will.
Perfect. So in 3 years of old child, if you are having a palpable mass with hypertension, with hematuria, think of Wilms tumor, right? This is going to be one of your MCQ as well. Okay. How do we get this Wilms tumor? It's basically a mutation of WT1. Thanks God, the gene name is very simple. Wilms tumor 1 mutation, right? And it can be accompanied by 2 syndromes, Weger syndrome. We're going to discuss Weger syndrome and Beckwith-Wiedemann syndrome. But you should just keep in mind, it can be, in this syndrome, Wilms tumor can also be present. So the Weger basically stands for Wilms tumor, aniridia. What is aniridia, by the way?
Virus. Absence of
Absence of iris.
No iris.
Okay, your absence of your iris, right? Your eye. Genital anomalies along with mental and motor retardation. Just memorize it, and we are going to discuss this in detail once topic of Weger syndrome would come, right? In our genetics. Okay, the other one is Beckwith-Wiedemann syndrome. Again, we are going to be having Wilms tumor, neonatal hypoglycemia, muscular hemihypertrophy. What do we mean by hemihypertrophy? Half of his body is going to be hypertrophy. Organomegaly, big organs, big tongues, right? So this is going to be a general presentation for Beckwith-Wiedemann and Weger syndrome. And both of these syndromes, Wilms tumor is going to be present in that individual. Is that clear?
Yeah.
Yes.
Perfect.
Yes, sir.
So now we are only left with our last topic of cancer, that is lower tract carcinoma, right? Lower tract carcinoma. Lower tract carcinoma. Okay, first of all, how to differentiate, in an individual who is just coming to a clinic, and how to differentiate whether it's a upper tract carcinoma or lower tract carcinoma. So that's really simple, right? For example, let's suppose these are your kidneys, right? Your kidneys are going to come down. It's going to be connected with your bladder, right? For example, if you're seeing hematuria, right? So hematuria can either come from, from your lower tract, either it can come from your upper tract. Like only seeing blood within the urine cannot differentiate whether it's an upper tract or lower tract. Is that clear? So what we are going to do, like if you guys remember you were having an MCQ, we are going to insert a scope with a camera. If you're seeing blood oozing out from the trigone, we are going to assume that blood is coming from the upper kidneys, right? From the upper kidneys, and more probably there's going to be present a problem here within the kidneys. For example, renal papillary necrosis can lead to that, nephrolithiasis can lead to that, cancers can lead to that. But if we do not have any bleed here, but again we are seeing blood within the urine, so most probably there is going to be any kind of problem or tumor within the bladder, right? That's really important to keep in mind. Okay, so the first cancer of your which we are going to discuss is urothelial carcinoma.
Excuse me.
Yes, please.
I can't understand that. What's the difference between lower tract carcinoma, the blood in urine? I can't understand that.
So, I want to basically mention a simple concept, right? For example, if you are seeing blood within the urine, right? Blood within the urine. So only indication of blood cannot give us any idea whether the blood is coming from the lower urinary tract or whether the blood is coming from the upper kidneys, right? Hello?
Yes.
So for that, what we are going to do, we are going to insert a camera and we are going to see things, right? If we just found any tumors here, that can just tell us that whether, the cause is bladder, right? So we have to insert a camera. But if you are seeing, like there was one of your UL MCQ, if you guys remember, about renal papillary necrosis of your anatomy, I guess that was your anatomy. They were just telling you we have a trigone structure, remember, where the ureter are inserted. The area was known as trigone, right? And there we are seeing blood oozing out of that small 2 slits where your ureter are inserted, right? So, for example, if I inserted a camera and I do not see any masses here, right? And then I just visualize that area of trigone with the slits, and I'm seeing blood oozing out from there. So it's going to give me a clear idea that the blood is basically, the source of the blood is basically your upper urinary tract, okay, especially your kidneys. And
Yeah.
that can be due to renal papillary necrosis, nephrolithiasis, that is irritation of the stones leading to formation of, blood. Again, your nephritic syndrome as well, right? Because from the glomeruli, the blood was just coming, right? So this was the main idea which you should just keep in mind, right? Sometimes they can ask you MCQs like that we have hematuria, we inserted a camera and this was the source of blood. What do you think? So you should just think like that once you just get MCQs related to, bleeding or any kind of things like that, okay? Is that clear now?
Yes, thank you.
Okay, thank you. So the next topic which we are going to discuss is urothelial carcinoma. Urothelial carcinoma. We have a word carcinoma. So what do you guys assume? Is it a malignant or a benign cancer?
Malignant.
It's a malignant cancer. Perfect. Urothelial. We know that urinary tract is basically lined by an epithelium. We also call that urothelium or transitional cells epithelium, right? Hello?
Yes, sir.
So your entire tract is lined by this kind of epithelium. So if you have carcinoma of that epithelium, it means it can be in the renal pelvises, it can be in the ureter, it can be in the bladder, it can be in the urethra, because all of these structures are lined by the same epithelium. Is that clear? Hello?
Yes.
Okay.
Yes, sir.
But
Yes,
most common type of lower tract is going to be, like, most commonly it's going to arise in the bladder. Keep that in mind.
Bladder.
Okay? Okay. What is the, okay, if you have formation of cancer, we already discussed that for the formation of cancer, there should be a triggering event, that is chronic irritation, right? So what would be irritant in this case, in this case of urothelial carcinoma or transitional cell carcinoma development? What is going to be the chronic irritant? It can be smoking.
Also smoking
It
particles.
can be, okay.
Yes.
And what, especially in the smoke, which component of your smoke? Naphthalamines, right? Hello? Hello?
Yes.
Okay, we
Yes,
have,
sir.
if you
Yes,
guys
sir.
remember, in the smoking, in the smoke, basically we have, yes, aromatic hydrocarbons, something like that, right? Polycyclic aromatic hydrocarbons that are carcinogen. Naphthalamines can be one of the carcinogen present in your smoke. So that's going to, okay, that's really important, naphthalamine. Keep that in mind. You guys are going to be asked on this as well, right? Naphthalamines. Okay, what else? Azo right? And he dies. We have an individual, he was, a hairdresser.
Textile. Yes.
Suddenly he developed a cancer of bladder. So you should just think of the causative agent behind that is going to be dyes. Long-term cyclophosphamide and phenacetin use as well, right? These are the drugs which you should just keep in mind. It can lead to cancer. And what's the main idea? The main idea is chronic irritation. Is that clear? Hello?
Yes, sir.
Okay. So what is going to be the presenting features? There is going to be again hematuria, because we have cancer, can have a lot of blood vessels, but this is going to be a painless hematuria.
Painless.
Right?
Yes.
Perfect. Painless hematuria. So there are two pathways for this cancer to develop. Two pathways. One of the pathways is known as flat pathway. The other pathway is known as papillary pathway. So what do we mean by flat? We have a flat epithelium. It can directly lead to formation of cancer. We have epithelium. First of all, it can lead to papillary processes like that. Well, these kind of structures are not, the finger-like projections are known as papilla, right? Hello?
Yes, sir.
Yeah.
It can also lead to formation of, okay. Remember, in development of flat pathway, in the flat pathway which we are discussing, it's basically going to be a high-grade flat tumor, and then it's going to invade. It's going to be a high-grade tumor, and it is directly going to invade, because it's a malignant cancer, right? And malignant cancer loves to invade, associated with early P53 mutation. If you have P53 mutation, P53 is again a tumor suppressor gene, right? So if you have mutation of P53, it means we won't be having a tumor suppressor gene, no one to suppress your tumor. So the likeliness of development of tumor is going to be more, but it's going to be a high-grade tumor with invasion. While in case of papillary carcinoma, again, it's not associated with early P53 mutation. So it's going to be a low-grade tumor, then it's going to transition into a high-grade tumor, and then it's going to invade. Is that clear? Hello?
Yes.
So these are the two things which you have to keep in mind. So the next type of cancer which we are going to discuss is squamous cell carcinoma. It's a carcinoma. So you guys are going to be telling me, is it a malignant or a benign cancer?
Malignant.
Malignant.
Perfect. It's a malignant cancer. do we find any squamous cell in our urinary tract? Normally, do we have any squamous cells?
No, after irritation they become
No.
the
No.
No,
no.
Normally, we
There
do
is
not have any
transitional,
squamous
yes.
cells.
it's transitional.
Perfect. It means that, first of all, in order to get squamous cell carcinoma, first of all, we have to transform your cells into squamous cells. And what name basically we use for the word transformation of one type of cell into another type? What's the name of that?
Metaplasia.
Metaplasia.
Perfect. Metaplasia. And the example of metaplasia, Barrett esophagus, did you guys remember? Chronic exposure of your esophagus towards your acid is going to change the epithelial type into your,
Into the esophagus due to reflux from the stomach.
yes, reflux of acid. It's going to be a trick. Okay, is metaplasia reversible or irreversible? That's a question which you should think of.
Reversible.
Perfect. It's reversible. It's reversible if the triggering event is, withdrawn. It can reverse. It can get reversed, right? Okay. So for development of squamous cell carcinoma, we already know that it's a carcinoma. Carcinoma is malignant. We already know that we do not found any squamous cells. So in order to get squamous cell, first of all, we should be having metaplasia. So metaplasia is basically due to some certain things, right? Like in case of Barrett esophagus, it was due to reflux of acid, right? Here it is going to be due to, a bug, Schistosoma hematobium, right?
Yes.
Long-standing nephrolithiasis. Again, long-standing nephrolithiasis and Schistosoma hematobium are going to be, the trigger for transforming these cells into squamous cells. And once they are transformed into squamous cells, they can easily develop cancer, which is going to be called as squamous cell carcinoma. Is that clear? This is going to be really important. Just keep this bug in your mind. Schistosoma hematobium, really important. You guys are going to be asked on this, okay? Really important. Okay? Long-standing nephrolithiasis, chronically irritating your... Yes. Is that clear?
Yes. Yes. it
Okay,
is.
so the last cancer which we are going to discuss is adenocarcinoma. It's again carcinoma. So would it be a malignant tumor or a benign?
Malignant.
Oh. Okay, so if you guys remember, what was your allantois and what was your urachus? Remember? Yes or no?
Yes, sir.
Okay.
Remnants
discussed-
of
if you guys remember, we discussed that. Okay, perfect. We discussed that the dome of your bladder is basically connected with your umbilicus via allantois, right? And then what happens? Your bladder is going to come down. If this is your umbilicus, so what happens that it's going to lead to formation of urachus. An elongated, form of your allantois is basically your urachus, right? So this urachus have to obliterate, but if it do not obliterate, sometimes it can lead to formation of that cyst, right? And this cyst can keep on irritating your dome of bladder, which can lead to chronic irritation, and chronic irritation lead to cancer. But which kind of cancer? Adenocarcinoma, and it is going to be seen at the dome of bladder. Does it make sense? Hello?
Yes.
If it's an adenocarcinoma, so would we be seeing glandular structures?
Yes, adeno
Yes,
means glandular
adeno.
structure.
Adeno for glandular structure, right? Gland nuisance. We are going to see nuisance. We are going to see a lot of glands, right? Okay, bladder extrophy can also cause it. What is bladder extrophy? Anyone?
That's bladder anti-abdominal wall will be deficient and the bladder will be seen exteriorly.
Yes, it's going to be like some kind of present outside. It's going to be present like outside of your abdomen. You can see that, right? So in that case, if you do not have proper location of your, or proper orientation of your bladder, there is more chances of getting chronic irritation by surrounding structure. Again, there are more chances of getting, your patent urachus, urachal cyst. There are more chances of getting into adenocarcinoma. Is that clear?
Yes, sir.
Okay, so this was all about cancers. We are finished with this pathology section, and now we are going to be discussing our pharmacology, right? So pharmacology is really simple. Now, did you guys enjoy the session? Hello? I know already Dr.
Yes,
Moaz
sir.
have discussed this all of these things with you, but it was a kind of revision for you guys. Okay, so just give me a second. Okay, how's your preparation going on? Hello.
Dr. Ahmed, please, can you take
Yes.
this last one again? The uracos, the allantois from the uracos, and then irritation of the bladder. Can you take it one last time?
Okay, sure, no problem. Normally, remember one thing, right? For example, if this is your bladder, right? Your bladder, basically, the dome of bladder is basically connected with your umbilicus. So initially, the bladder used to be, formed inside your abdomen, right? Just keep this thing in mind. It's going to make the concept very easy. Your abdomen, right? And initially, like primitively in each and every individual, there used to be a connection between your umbilicus and your dome of bladder, right? And that connection was basically known as allantois. Is that clear?
Yes.
But as the individual grow, this bladder have to come down from the abdomen into your pelvis, right?
Okay. Yes.
But this connection still exists. So what would it do? It would just elongate this thing, right? This allantois, and it would just come down into your pelvis. And this elongated allantois is now going to be called as your urachus.
Uracos. Okay.
Right? No,
Yeah.
in normal individual, this urachus have to obliterate. It have to finish. It have to give you a ligament which is known as median umbilical ligament, right?
Yes. Yes.
Okay. But in some of individual, it can persist. If all of this urachus persists, so what would be the clinical features? You have a lot of MCQs on that as well. The urine can
Urine
just
coming
leak backward,
from umbilicus.
Can flow
and
back.
urine is going to be present around your umbilicus, right?
Yes.
Okay. But sometimes it can obliterate. Most of them can obliterate, but only a small portion here can just stay, right?
Yes.
Okay.
Yes.
Sometimes this small portion, okay, it's going to be called as a diverticulum, right?
Mm-hmm.
And you can have sometimes formation of cysts there. It can become infected, and once it's infected, it can lead to chronic irritation, right? Infection is going to irritate your bladder dome, right?
Yes.
And irritation lead to formation of cancer. That was the first point which I just mentioned before starting this lecture,
Okay.
right? So
Yeah.
in this case, the cancer would be adenocarcinoma of your bladder. Is it clear now?
Yes, that is clear.
Okay, perfect. So, okay, how's your preparation going on? I was asking that. Hello?
So I think another question of mine, because I'm really thinking deep into this. So if this, of course, this happens, this is an embryologic formation, and then it persists, giving us that diverticulum that could get infected and then leading to leading to bladder adenoma, right? How can it be? Can't it be detected early? Like, how would you know such? Or is it when it causes cancer that the person?
Okay, so basically, whenever you have like this infection or inflammation of diverticulum, so basically it's going to be like most of the time it's going to be undetected, right? It won't cause any problems, right? And you can only detect it whenever it causes cancer, right?
Oh, I see. Okay. Okay. Only when it causes cancer, then
Yes, and sometimes you're like, it can sometimes appear as an appendix whenever the diverticulum got inflamed. But most of the time it's going to be undetected, right? Until it leads to the formation of cancer. Okay, is that clear?
I got you. Yes,
Okay.
very clear. Thank you.
So let's discuss our renal pharmacology. Is going to be the last topic, as we already mentioned on Sunday. We're going to be having a big boot camp on this entire system. I'm going to cover it, and along with that, I'll be starting like already the pathology, I think, is really simpler for you guys. I just made it really simple for you guys. So you guys are going to be helping with pathology, and I'm going to review the physiology, right? So this is, and tomorrow we are going to start. Okay, so today you guys are going to be having, not today. From tomorrow onwards, let's start our respiratory section. Respiratory section is going to be really fun, believe me, guys, right? And I'm going to make it so simple. You guys, the physiology is really important and really confusing at the same time as well. But believe me, I'm going to show you, I'm going to make it really simpler for you guys, okay? So be there in the class, please. That's my request. If Dr. Muaz is taking session, we can just wait for him. If not, so I'm going to be having a regular session at this time, okay? So let's start our pharmacology. The first drug which we are going to discuss is mannitol, right? And mannitol is like, a really simpler drug, I would say. And it's very simple to memorize what's the mechanism of action of this. You can say drug, but it's basically not a drug, right? So mannitol, simply you can imagine, is a good osmol, right? It's a big osmol, which is going to stay within your blood. Just keep that in mind, okay? And we know what's the nature of osmols. Osmols love to attract fluids. You already know that, right? Hello?
Yes.
Okay.
Yes.
So
Yes.
it's basically a diuretic. What do you mean by diuretic? Before discussing the pharmacology, I'm going to give you a generalized concept how to memorize these drugs. What's the function of these drugs? Diuresis basically means whenever we are urinating more.
Yes.
Right? Whenever we are urinating. So how mannitol can cause diuresis? The idea is really simple. Mannitol can filter through your glomeruli. That's the main thing which you have to keep in mind. And as the mannitol filters through your glomeruli, it's present in your proximal convoluted tubule. So it's a good osmol. It would attract a lot of water toward itself. And as it moves in the urine, so it would just cause diuresis, right? So can I say that it's an osmotic diuresis? Because due to the, it have a power of good osmol. It's going to attract fluid with itself. And as it is leaving out of your urine, it's going, along with it, it's going to, take a lot of water with itself as well. So let me just call it as osmotic diuretic. Can I call that?
Yes.
Okay.
Yeah.
So that's really simple. What's the uses of mannitol? Whenever you just give mannitol, it's going to be present within the blood. And as it is a good osmol, so what happens? Whenever it is present in the blood, it's going to attract again a lot of fluid from the surrounding areas from the interstitium. So for example, if you have an individual and he's having increased intracranial pressure, or let's suppose cerebral edema, right? Cerebral edema, or if he's having glaucoma. What is glaucoma? Both of these things are basically increased pressures, right? Like for example, how can one get intracranial increase pulmonary edema if someone, intracranial or cerebral edema if someone is having any trauma to brain, right? So trauma can lead to edema. For example, if the glaucoma, if you have an open angle or a closed angle glaucoma, we are going to be having a lot of fluid in the eye, which is going to cause a lot of pressure. So if we just give mannitol, what happens? This mannitol is going to suck all of the fluid from the brain and the eye. And in this way, can it help an individual with intracranial, increased intracranial pressure or glaucoma? Yes or no?
Yes.
Yes.
And as it pull a lot of water and it's moving out through your kidneys, again, it's going to pull a lot of water. It's going to cause diuresis, right? So it can be used as a diuretic, and as well it can be used in case of increased intracranial pressure or intraocular pressure glaucoma. Is that clear?
Yes.
But
Yes.
what's the clinical use? We already discussed. Okay, so what's going to be the adverse effect? The adverse effect, if it keep on attracting a lot of water, can it cause dehydration? Very simple, right? And if it pulls a lot of water with itself, what would happen to the remaining sodium in your body? It's going to become concentrated, right?
Yes.
It's going to become, so can it lead to hypernatremia? Yes.
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 But if it's present within the blood and it's attracting fluid from the interstitium, so what it's going to lead to hyponatremia in that case, because it's going to dilute your Na. Am I right?
Yes.
Can we use it in pulmonary edema? Yes. Again, yes. It's going to suck all of the fluid from your interstitium. So we can use it in pulmonary edema, right?
But at the same time, it can cause pulmonary edema also in case of
It's the adverse
heart
effect
failure.
of this drug too.
Yes.
Yes.
Yes, it can cause pulmonary edema as well, right?
Yeah.
Okay, what's the contraindication? Heart failure. So in
Heart
heart failure,
failure,
we
yes.
are already in volume overload states, right? Our heart cannot bear more volume. Our heart cannot bear more stress. So please avoid this drug in heart failure, okay?
Yes.
Is that clear? Perfect.
Yes.
And then, okay, is this pharma clear?
Yes, dear.
Yes, it is.
You guys know that I usually do not teach this pharma, but when I teach it, so it's a kind of, simpler version of pharma, I would say. Because this is the way I remember pharma. I don't like pharma, by the way, okay? So the next drug which we are going to discuss is acetazolamide. What is acetazolamide? One thing which you have to just keep in mind. It basically inhibits your carbonic anhydrase. That's all. That's all. Yes, that's all which you have to keep in mind. So now let's discuss what's the function of carbonic anhydrase in different part of your bodies. You know what is aqueous humor? You guys know
Repeat again, sir.
what is aqueous humor?
The anterior
Okay.
The fluid in the
For example, if
eye.
this is your eye,
fluid in the posterior compartment.
the lens, so here is you are going to be having a ciliary body. So ciliary body basically make your aqueous humor. This is going to go inside your anterior chamber and drain into canal of Schlemm. Remember? But
Yes,
if you
yes,
have
yes.
formation of more aqueous humor, it's going to lead to glaucoma. Right?
Glaucoma.
And what this glaucoma is going to do is going to compress your optic nerve, giving you optic neuritis, right? Degeneration of optic cupping. If you guys remember someone
Yes.
from ophthalmology.
Permanent blindness also.
Permanent blindness, right? So carbonic anhydrase is an important enzyme which helps in formation of aqueous humor. So can we use acetazolamide in glaucoma in order to inhibit carbonic anhydrase, in order to inhibit formation of your aqueous humor, in order to, help individual with glaucoma?
Yes.
Yes? Okay, that's great then. Okay, remember your proximal convoluted tubule. How do proximal convoluted tubule reabsorb your bicarbonate? You remember that whenever H plus move outward, it's going to react with this. It's going to form H2O plus CO2. CO2 is going to come back. Again, CO2 is going to react with your H2O. It's going to lead to formation of H plus and HCO3. And HCO3 is going to be reabsorbed. Remember the physiology?
Yes, sir.
Okay.
Yes.
But both of these reaction again requires carbonic anhydrase and carbonic anhydrase. Right? Hello?
Yes.
Yes.
Okay. So if I'm inhibiting this carbonic anhydrase by using acetazolamide, so would I reabsorb HCO3? Yes or no?
Yes.
Yes.
HCO3 will not be absorbed.
No,
If inhibit,
I'm
no.
not
Yes.
I'm inhibiting, I'm giving acetazolamide, I'm inhibiting carbonic anhydrase. So would I reabsorb HCO3? No. I won't reabsorb HCO3. HCO3 normally bond with Na as an NaHCO3, right? So it would just leak out in your urine, and simply you can just think of, as it leaks out in your urine, it's a good osmol again. So it would pull water with itself as well. So can I say that acetazolamide is again a good diuretic?
Yes.
Hello?
Yes.
Okay, it's a
Yes.
good diuretic, but it basically alkalinizes your urine, because while using acetazolamide, you cannot reabsorb HCO3. HCO3 is going to remain in the urine. The bases, whenever present in the urine, alkalinizes your urine. Is that right?
Mhm.
Right?
Yes.
Okay, if I am decreasing HCO3 stores by administration of acetazolamide, it would just resemble one of a pathology, if you guys remember, right? It would just give me acidosis, right?
Metabolic acidosis.
Mhm.
Metabolic acidosis is going to give me acidosis. And did you guys remember Fanconi syndrome?
Mhm.
Yes.
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 What was your
Proximal,
Fanconi syndrome?
Mhm.
proximal convoluted tubule.
Failure of proximal
Damage.
convoluted tubule. Perfect.
Damaged
So
by
what would be the
expired tetracycline.
perfect? So let's discuss the clinical uses. Can I just use this drug in glaucoma?
Yes.
Yes.
As mentioned here, we can just give it in glaucoma, right?
Mhm.
Okay, if an individual is having metabolic alkalosis, how can one get metabolic alkalosis? An
Loss
individual
of
climbing,
esters.
an individual climbing
Vomiting.
okay, perfect. Vomiting.
Metabolic. Yes. If respiratory by high altitude is respiratory alkalosis.
Perfect. Like if you're vomiting, we can just get alkalosis because we are losing the acids, right? Similarly, if you are moving up high altitude, it's again going to trigger metabolic alkalosis. Why? Because we are going to hyperventilate. Like that. In hyperventilation, basically we expel out your CO2. CO2 is acidic, and then we are going to have metabolic alkalosis. So would I give acetazolamide in that case? Yes or no? In order to neutralize your acid balance. Acid
Yes.
base balance. Perfect. Can I use it in idiopathic intracranial hypertension? Yes or no?
Yes.
Again, it's a good osmotic, a diuretic. Okay, perfect. So what is going to be the adverse effect? That's very simple. For example, if it keeps on, if we exaggeratedly overdose an individual with acetazolamide, and we aren't reabsorbing a lot of NH3, the bicarbs. So what would happen as a result of that? It's going to lead to
Metabolic acidosis.
acidosis. Okay, perfect. And type 2 metabolic RTA, remember? Type 2 RTA.
Yes.
Type 2 RTA, perfect. Right? Okay. So basically it can have NH3 toxicity as well. Okay, what is NH3 toxicity?
Ammonia toxicity.
Ammonia toxicity, right? So it can have a sulfur-like allergy as well. You can just, it can lead to hypokalemia. How? The idea is really simple. If you are diureting a lot, if you are just losing a lot of volume, so the RAS system is going to be activated, right?
Mhm.
So RAS system can lead to hypokalemia, right?
Yes.
Okay, promote calcium phosphate stones as well, right? Because for the formation of calcium phosphate stone, basically it become insoluble. The urine pH is more alkaline, right? Keep that in mind.
Mhm.
Okay, so this was all about these two drugs. Let's discuss our further next drugs, that is loop diuretics and thiazide diuretics. Really important and really simple as well. If you guys remember, we have a transporter in thick ascending loop of NLA. What was the name of that? Yes, please, just tell me.
Sodium potassium chloride.
M2 chloride.
Plus and 2 chloride.
2 chloride.
Yes.
So
Okay.
chloride.
So what your loop diuretics is going to do? It's going to inhibit this.
This transporter.
So this transporter. If this transporter is inhibited, so what would happen to the level of Na in the blood? Decrease, right?
Mhm.
What would happen to potassium?
Decrease.
Decrease. What would happen to the calcium?
Decrease.
No, sorry, the chloride.
Chloride.
Decrease.
Decrease.
You guys know that how does the HCO3 get reabsorbed in the blood? That's also really important. That's basically dependent on your level of chloride as well. Do you guys remember that?
Mhm.
Okay,
Yes.
if we have hypo, we have less chloride, what would happen to the reabsorption of HCO3?
Increase.
Increase or decrease?
If we have less chloride, it will increase to compensate the negative.
Okay. So let's discuss that what would happen. Okay. So the main goal is that whenever the Na isn't reabsorbed, so Na again is a good osmol, it would just attract a lot of fluid with itself. So it would call diuresis. So can I just call it as a diuretic drug?
Yes, it is a diuretic.
Yes, it is a diuretic. Perfect. So basically, what's the other function of this? Okay, the clinical uses. So what do you guys think are going to be okay? What do it do to the calcium level? That's also really important. If you guys remember the physics, right?
Decrease. Loop decrease calcium.
Yes, decreases the calcium. Decreases the calcium because
decreases the
we discussed that the calcium and magnesium are basically reabsorbed via paracellular routes, and we need this channel for the reabsorption of calcium, right? So if we have blocked this calcium, these channels, so we won't be reabsorbing the calcium as well. So it's going to lead to hypocalcemia or hypercalciuria, right?
Yes.
Okay, and a
Hypercalciuria.
really important thing. Did you guys remember a condition? Did you guys remember a condition known as SIADH?
Yes.
Yes.
Okay, what is SIADH? I want you guys to be summarizing that for me. Then I'm going to tell you the significance of these drugs in SIADH.
There is inappropriate release of antidiuretic hormones.
Antidiuretic
Too much,
Okay.
antidiuretic hormones.
So we have a lot of ADH. Simple,
Yes.
right? A lot of ADH is going to come into your kidneys. It's going to install a lot of aquaporins and V2. And due to
Yes. That's water.
hyperosmolar interstitium, it's going to lead to reabsorption of water, right? So it's your interstitium which is helping your water get reabsorbed from your tubules. So what your loop diuretics do, that's really important, it's going to wash out this hypertonic environment, right? It's going to wash out the osmoles which are present here in the medullary section, which basically leads to reabsorption of your water. So if you are giving loop diuretics in order to wash out that area, so would it help an individual with SIADH?
Yes, it helps.
Yes, because if you are just washing out that concentrated area, now you do not have the driving force to reabsorb the H2O. You lose the driving force. If you lose the driving force, now all of the outcomes of SIADH can be treated in this way. Okay, is that clear?
Yes.
Okay. What do loop diuretics?
Repeat, Dr. Ahmed, could you please repeat this concept?
Okay, let me just repeat it. Okay, just give me a second. Give me 1 second, please. Okay. I think there's something wrong with my mic. Just give me 1 second, please. Hello, can you guys hear me?
Yes.
Yes.
Okay. So we were discussing SIADH. What is SIADH? Syndrome of inappropriate ADH. We're going to be having a lot of ADH. And what's the function of ADH? It's going to reabsorb more water, right? Right. In this condition, we are going to be having more reabsorption of water. Am I right? Hello?
Yes.
It's going to cause problems for me, right? It's going to cause problems for me. Okay. So how does the water get reabsorbed in your collecting ducts normally? We know that the medullary portion there is very concentrated, right? You have a lot of osmoles present in your medullary section of your kidney, simply you can imagine, right? A lot of osmoles. And we know that the osmoles love to attract water, right? Hello?
Yes.
Yes.
Especially
But as
urea. Yes.
these tubules are impermeable to water, so we need ADH. So what ADH is going to do? ADH is only going to make doors or pathways in that tubule, and it's going to increase the permeability only. Now it's the goal of your concentrated or hyperosmotic interstitium to pull all of the water. That's a normal process, right? Normally, that's how your ADH function. Is that clear? Hello? ADH
Yes.
does not directly act as a pump and reabsorb water. Normally, ADH only increases the permeability of tubules. It's the goal of your hyperosmolar interstitium, which reabsorb water. Is that clear?
Yes. Yes.
That's a normal process. So in SIADH, we already have a lot of ADH. We already have a lot of doors. So how can I help this individual? Let's just remove these pumps. Let's start on. And what are these pumps made of? These are made up of hyperosmolar, like substances like urate, right? They're hyperosmolar. They basically act as a pump for reabsorption of your water. So loop diuretics basically wash out these hyperosmolar or hyperconcentrated ions or osmoles. So in this way, I can help an individual with SIADH. Is that clear now?
Okay.
It's clear.
Okay.
So it's
Perfect.
another function of the loop diuretic.
Yes, it's another function treatment for your washing out your concentrated interstitium.
Interstitium. Okay.
Simple.
Perfect. Thank
Okay.
you.
Okay, perfect. So the clinical use, edematous states, it's a diuretic. So I think you should know the clinical uses, right? Can I use it in hypercalcemia?
Hypercalcium. Yes. Because
Yes.
hypercalciuria, it will
Yes.
reduce the calcium.
Perfect.
Yes.
Perfect. Would it cause hypokalemia?
Yes.
Yes.
We are discussing the adverse effect. It also
Yeah.
causes autotoxicity, right? That's really important.
Yes.
You're going to be having a
If have combination with gentamicin,
if in combination with aminoglycosides.
that's right.
Okay, if you guys remember certain certain drugs cause nephrotoxicities, right? Penicillin, do penicillin causes nephrotoxicity? Again, really high yield. Yes or no?
Penicillin derivated can cause interstitial nephritis. Yes.
Okay, it can cause interstitial, but I'm asking
Yes.
about the nephrotoxicity in the end. Yes.
Yes. Yes.
Yes.
Then
Yes, it can cause.
Yes.
vancomycin. Does vancomycin causes any kind of nephrotoxicity?
Yes.
Yes.
Aminoglycoside. It also causes a lot of nephrotoxicity, right? If you guys remember
Yes.
the sketchy videos with the jello
Yes.
beans, right? Just do your sketchy videos and everything is going to be really simple for you guys, okay? So it can cause, okay, this is going to be one of your reward MCQ. Again, the loop diuretics along with that, the aminoglycoside, two of your reward MCQs. Very important, okay? So besides that, it can lead to dehydration, it can lead to sulfur allergy, metabolic alkalosis, right? If we have exaggerated response of your RAS system, right? It can lead to alkalosis, right? And interstitial nephritis, okay? Is that clear?
Yes.
Okay. So there was a genetic problem which was same as that of if an individual is using loops diuretics. What was the name of that? Liddles or Jittelman?
Can you repeat your question? Please, can you repeat your question?
Okay, my question is that we were having a genetic problems. We discussed in our pathology section. I think with Dr. Moaz, we might have discussed did
Yes.
that. Gentleman, Liddles. Remember Gentleman, Liddles,
That's Barter syndrome. I think.
Barter syndrome,
Barter.
Barter, Gentleman's Liddle.
Middle, yes.
You know,
Yes.
one of that syndrome was same as that individual was using loop diuretics, because the problem there was again with these channels as well. So it would cause everything similar at that as that of using. So what was the name of that pathology? Simply, I'm just asking you.
Barter syndrome.
Part
Barter.
is the dome causing this ascending part and
Gentleman.
little collecting duct,
Thiazide.
Little.
Yeah.
And thiazide, DCT.
Okay, perfect. Can you guys just give me a second? I have an important call.
Okay, please.
Just give me 1 second. Thank you so much for your.
Sorry, guys. So the loop diuretics act like barter or Gittleman? I didn't understand.
Barter. Barter.
Barter.
Thank you.
Hello. What was your question?
Yes.
Nothing. It's solved. I said that it's like a barter or Gittleman syndrome, and I understand that it's like a barter syndrome.
Okay. Okay. Just give me a second, please. Okay. Anyone who can just clarify this doubt, please.
Yes. So in case of Barter syndrome, there will be defect in the loop of Henle sodium potassium 2 chloride channel, and patient will be having like same effects, hypokalemia, hypercalciuria, and all these.
Thank you so much.
You're welcome.
Yes, and the gentleman is in the DCT. There is also defect in the or decrease the reabsorption of sodium chloride. And little also, I think little in collecting duct. But yes, anybody confirm?
Yes, yes, that's in collecting.
Yeah.
Hello.
Yes.
Okay. So, okay, where were we? Okay, we were discussing the. Okay. So, the next one which we are going to discuss is thiazide diuretics, right? So, thiazide diuretics is going to be our last topic for today, and after that we have like very simple drugs, ACE converting enzyme. Dr. Moaz is going to do that with you guys because he texted me that he's going to continue the sessions. But it was a kind of, you can say, a revision for you guys. Okay. So the last one is going to be thiazide diuretics. Okay. Thiazide diuretics. So what's the function of thiazide diuretics? It's really simple. It's going to inhibit channel within your distal convoluted tubule. Okay. DCT, distal convoluted tubule. Okay. And in the distal convoluted tubule, if you guys remember, what was the channel present there? Hello.
Sodium chloride.
Sodium chloride.
And after Japanese.
Hello. Can you guys hear me?
Yes, now we
Yes.
can hear.
Okay. So basically, the function of parathyroid hormone was to reabsorb calcium there. So you should just keep in mind whenever we are inhibiting the NaCl channel here. So by inhibition of NaCl channel, you are doing nothing with reabsorption of calcium because calcium is not under the influence of this channel. Calcium reabsorption is under the influence of your parathyroid hormone. Okay, so this is the main differentiating feature between loop diuretics and thiazide diuretics. Like in the loop diuretics, we discussed that the reabsorption was basically tethered with the function of your channel, but here the reabsorption of calcium isn't tethered with the function of your channel. It's basically under the influence of parathyroid hormone, right? So whenever we are giving thiazide diuretics, it won't cause any hypocalcemia or hypercalciuria. Okay, is that clear? Hello.
Yes, clear.
Okay, so it won't cause any problems with okay, so you'll be seeing a lot
No,
of
sir. My question is then why we are not indicating or prescribing in case of renal stones? Because I think it's increased the calcium absorption in the
yes, it
DCT.
increases the calcium reabsorption basically,
Yeah.
right? So it do not causes hypocalcemia or hypercalciuria. That was my main point, which I want to indicate. Okay, so we have an individual. He was having osteoporosis, right? And he was basically in volume overload states. So we are basically giving him certain kind of diuretics. So what do you think? What would be your choice? Loop diuretics or thiazide?
Thiazide,
Thiazide. Thiazide.
because of hypercalcemic effect of thiazide.
Or because of hypercalcemic effect of thiazide diuretics, basically you are helping this individual. He already is having a history of osteoporosis as well. So you cannot give him loop diuretics in order to worsen the problem, right? Okay. So as it is inhibiting the NaCl channel, again, the idea is really simple. NaCl is going to leak out. And as the NaCl leak out, it's going to attract water with itself as well, right? So if the water is attracted, it's going to be a diuretic, right? Okay. So diuretic can be used in hypertension, heart failure. Again, we already know nephrogenic diabetes insipidus, osteoporosis as well in this case. Okay. So, hello, are you guys following me? Hello.
Yes.
Okay. So
Yes.
if you have okay, so what would be the adverse effect of thiazide diuretics? That's very simple. If you have a lot of diuresis, the RAS system is going to be activated, right?
Yes. Hyperkalemia.
Okay. Hypokalemia, because if we are just giving diuretic, if we have a lot of diuresis, so what would happen as a result of that? We are going to be having decreased effective circulatory volume, decreased NaCl delivery to macula densa, RAS system activation, which is going to lead to metabolic alkalosis as well, because it's going to kick off your K plus along with your H plus, okay,
Yes.
and hyponatremia in that case. Okay, so it can lead to hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia and sulfur-allergy, right? So that's a mnemonic hypergluc, right? Just keep that in mind. And that's all about today's session. So Dr. Moaz just contacted me. He's going to take the sessions. And that was all for me. Hope so you guys enjoyed the session with me. So I'll just discuss with Dr. Moaz again. If we do not have any session, if due to some mishaps, if the session is missed in the morning, so then we are going to take session at this time. Okay, and I'm only going to do a revision with you guys. Okay, so thank you so much, and
Okay.
please
Thank you. Thank you, sir.
sessions. Okay, I'll just try my best to take it every day, but as you guys know that Dr. Moaz is your main mentor, so that's why I'm only going to be there whenever it is. Yes, as I have already mentioned, if he's going to settle down, he's going to take the sessions on daily basis. But if there is any kind of issue, then I'm going to take over the sessions. Okay, so you don't have to be worried. Everything is going to be covered on time. You are at your back. Dr. Mahin is also going to come back. Thank you so much. Thank you and have a nice day.
We have to wait for Dr. Moaz, or we have to leave the session. Any idea?
Don't know.
What Dr. Ahmed? What I say is now the listen that he told that Dr. Moaz will join the session, and he will continue. What?
Yes,
Or we have to leave? Mhm.
but Dr. Moaz is not in class yet. Are we supposed to ask him? Maybe we should ask him in WhatsApp.
Okay. Thank you.
Hey, everyone in the WhatsApp group, you said to leave the session so that it can be uploaded.
Thank you. It's better to leave now.
Yeah.
Thank you.